All right, I think we can go ahead and get started. So hello everyone, and thank you for joining. On behalf of the Tiny Baby Collaborative, I'd like to welcome you to the Tiny Webinar series. My name is Noelle Young. I'm an assistant professor of pediatrics at Duke University School of Medicine, and I'll be helping to moderate this session today. As you'll hear more about in today's webinar, the Tiny Baby Collaborative is an international group of clinicians and researchers that was formed with the mission of trying to understand how we can improve care of infants born at or before 23 weeks gestation and their families. Next slide, please. So we've put together this webinar series to address some of the unique management considerations in caring for these infants. And following today's webinar, you can see that we'll have future webinars that will address specific topics that we thought were key challenges in caring for this population. And information on how to register for these webinars will be forthcoming, so please keep an eye out for it. All right, next slide, please. So first, just for a few quick housekeeping items. This webinar series will be recorded, and all recordings will be posted to the Tiny Baby Collaborative website. It's our goal for these webinars to be multidisciplinary, and please note that we do welcome families of extremely preterm infants. We encourage everyone's participation and just ask that you're respectful. Thanks to everyone who submitted questions ahead of time in the registration form, and you may also put any additional questions that you have during the webinar in the chat, and we'll have time to address some of these questions at the end. All right, next slide, please. All right, so here you can see just a quick snapshot of who's in attendance today. Most of our registered attendees are attending physicians, but we're happy to also have the participation of nurses, trainees, researchers, parents, and others representing more than 20 countries. We're very excited and grateful for your participation in this webinar. Next slide, please. So for the agenda today, we'll first hear from Dr. Angela Kribs about the experience of her center in treating these extremely premature infants. Dr. Kribs is the head of the Department of Neonatology at the Children's Hospital of the University of Cologne in Germany. She's an accomplished researcher and has extensive clinical experience in caring for these infants. And then following her talk, we'll hear from Dr. Matthew Rysavy about what we know, don't know, and how we might learn. Dr. Rysavy is an assistant professor of pediatrics at University of Texas Health in Houston, and he's also the director of neonatal clinical research there. His research has made really important contributions to understanding variation in care and outcomes for these infants, and he and Dr. Kribs are co-chairs of the Tiny Baby Collaborative Steering Committee. And joining me, we have two guest expert moderators. Dr. Cheryl Battersby is an NIHR clinician scientist and clinical senior lecturer in neonatal medicine at Imperial College in London and honorary consultant neonatologist at Chelsea and Westminster Hospital. She's also the data and informatics lead for the British Association of Perinatal Medicine. And Dr. Danielle Arrett is Chief Medical Officer and Director of Global Health at the Vermont Oxford Network, and an Associate Professor of Pediatrics and the Asfa Umiru Green and Gold Professor of Global Health at the University of Vermont Larner College of Medicine. So thank you all for joining, and I'll go ahead and turn it over to Dr. Kribs. If you can just unmute, please, Dr. Kribs.
So thank you for the kind introduction, and thank you also for the great opportunity to share our experiences with such a big part of people. I want to speak with you about the care of infants below 23 weeks from the perspective of a single German center. And I want to start by going back 25 years ago, where we had the first infant that we treated with a gestational age below 23 weeks. It was in the year 1998, and there was a mother who presented in our Department of Obstetrics with the second pregnancy. She had already a first child, and this child was healthy. She presented at week 19 of gestational age, and she had a vaginal bleeding, elevated leukocytes, and an elevated CRP. The obstetricians and the midwives were very convinced that the pregnancy would end in an abortion, and they proposed to the parents termination of pregnancy. But the parents declined this proposal, and they chose expectant management. So the mother stayed in the hospital. She received antibiotics only for maternal indication, no antenatal steroids or tocolytics, and the bleeding first ceased. 3 weeks later, at the gestational age with 22 weeks and 5 days, the mother presented in labor. The obstetricians and the midwives still presumed a stillbirth, and so no neonatologist was called for the birth of the baby. But the baby was born alive after 10 hours of labor, and after 30 minutes, the baby was still alive with improving condition. And therefore, the obstetricians and the midwives called for the neonatologist. Examination on arrival revealed an extremely preterm infant with signs of extremely prematurity, a pink skin, limited but appropriate movements, regular but labored breathing, and a heart rate above 100 with nearly 120 to 130 per minute. And so the called neonatologist asked the question, what shall we do? What is to do? And this is really a big question, and 25 years ago, it was not easy to answer. And we decided in this acute situation to follow the guideline from Hippocrates, primum non nocere, that means first of all, do not harm. Secundum cavere, secondly, be cautious with everything you do. And thirdly, try to heal the infant. The parental wish was very clear. The parents want that the baby was supported, but suffering of the baby should avoid it as far as possible. So we decided to do clinical management focusing on avoidance of suffering, but also of supporting the infant's abilities. So we started with an CPAP with a variable flow device, the Benveniste valve, at a PEEP level of 8. And we started as fast as possible enteral feeding with mother's own milk that was expressed by the mother. We put the baby in an incubator and we monitor it by pulse oximetry. We inserted a peripheral venous line for infusion of a standard parenteral nutrition, and we observed during the following days a stable, spontaneous breathing infant. After 7 days, the baby was intubated and put it on ventilation due to recurrent apnea. And there were several episodes of mechanical ventilation for 2 to 3 days for in whole 3 weeks. But the baby survived without major complications. The baby had during the course some causes of antibiotics due to suspected infections. And this baby raises a lot of questions and discussion in our team. At the time the baby was born, there was an existing guideline in Germany for preterm infants at the border of viability. This guideline said that babies below a gestational age of 22 completed weeks usually should not actively be treated, but provided comfort and palliative care. Between 22 weeks and 0 days and 22 weeks and 6 days, it was proposed only to treat the babies actively on explicit parental request. Between 23 weeks and 24 weeks, active treatment should be done after shared decision-making with parents, and after 24 weeks, every baby should first treat it actively. But this guideline only addressed the question whether to active treat the infants, but not how to provide active treatment. And in our team, we had the big discussion, what should we do with the baby? How should we treat it? Should we intubate it? Should we only do CPAP? And if the baby was not comfortable with CPAP or not stable with CPAP, should we let the baby die? It was a big discussion in our team. And in this discussion, we came to some key points that was a basis of our approach to care for these very tiny and very immature babies. And the first statement was what is of highly importance for our decision, or what was of highly importance of our decision to think of treating these babies actively already 25 years ago, was the observation that many of these extremely preterm infants are not dead after birth, but they show signs of vitality. Due to their vitality, they do not need resuscitation, but they require some kind of care. And a very important thought is that preterm infants are adapted to physical and psychological symbiosis with their mother. And if they are born, they need a substitute of this symbiosis. And therefore, parental and especially maternal wishes are of outstanding importance during the decision-making about active treatment of extremely preterm infants. And in the index case, the wishes of the parents were very clear. They decided against termination of pregnancy because they wanted their baby be alive. And after the birth of the baby, where the baby was alive, they wanted support for the baby. And we have to state that there is no option not to treat the infants. There is always a decision between active intensive care and palliative care. But if we decide for active intensive care, there are some unanswered questions, and they are still until now unanswered. What is the best way to treat this infant? And is it really the best way to translate therapeutical strategies that we use in more mature infants to these extremely preterm infants, or should we perhaps look for other strategies? And to make clear our approach, I think I have to a little bit to explain the history of our hospital, of our neonatal intensive care unit, and of the situation in Germany. You see the map of Germany, and you see here the state of Northern Westphalia, in which our town, Cologne, is situated on the beautiful River Rhine. And we have two children's hospitals in Cologne. One of these hospitals is a university hospital. And in this university hospital until 1992, we treated the preterm babies at the pediatric intensive care unit. In 1992, we founded the neonatal intensive care unit that was located in the obstetrics department. And nowadays, we have 2,000 births per year, including 150 VLBB infants. And we are responsible for 3 obstetric hospitals with a total of 5,000 births. And the history of our unit is characterized by 3 milestones where we were successful in reducing the mortality of infants below 1,000 grams. You see here with the dark blue line the mortality of infants below 1,000 grams in the state of Northern Westphalia. And the light blue line is the mortality in our hospital. And you see, firstly, milestones that is very clear. The foundation of the neonatal intensive care unit in the obstetrical department led to a decrease of mortality nearly the mortality of the state of Northern Westphalia. And then there was a second milestone, and this milestone was in the year where our index baby was born. We introduced the use of CPAP to delivery room management of extremely preterm infants, based on the idea that we wanted to support the baby in his own capabilities. And there's a third milestone after the introduction of less invasive surfactant application via LISA in 2001. And during this period of about 20 years, we developed a protocol to assist preterm infants in their transition to extrauterine life. And the key features of this protocol are that we give antenatal steroids also to mothers of extremely preterm infants if the birth is expected, down to a gestational age of 22 weeks. We perform cesarean delivery also for this extremely preterm infants if it's medically indicated. We do delayed cord clamping, and we give a gentle support during postnatal transition and adaptation by immediate CPAP and positioning the baby in a comfort positioning. We support the spontaneous breathing by gentle stimulation. We do less invasive surfactant application after the initial stabilization in all extremely preterm infants. And thereby we minimize endotracheal intubation and mechanical ventilation during the first hours to less than 10% also of these extremely preterm infants. As soon as possible, we provide maternal bonding already in the delivery room, also for this extremely preterm babies, and we give breast milk for feeding. And in 2016, we published the results of babies treated according to this protocol with the gestational age of 22 and 23 weeks. And you can see that we have bigger number, bigger part of infants who receive primary palliative care in the 22 weekers than in the 23 weekers, but also in the 23 weekers, we have some babies who are treated primarily palliatively by parental wishes. And the rate of survival of active treated infants in this first observation was 61% for the infants with a gestational age of 22 weeks and 71% for the babies with a gestational age of 23 weeks. You see that 21% of the 22-weekers survived without inpatient morbidity and 28% of the 23-weekers. And in the follow-up of at 2 years, 50% had no impairment, 22% mild impairment, and 28% were severely impaired. According or as a consequence of these observations, the number of infants with a gestational age of 23 and 22 weeks increased during the last decade, but followed along with stable mortality. There was no increasing mortality. And I just looked for the numbers of the last 8 years after the already published cohort, and we see that there are some changes. The first change is that more 22 weekers are nowadays actively treated. 89% of the live-born infants with a gestational age of 22 weeks are actively treated. And 64% of this infant survived. That is not more than in the older cohort where less infants was actively treated. This means that the increase of active treatment goes not along with an increase of mortality, but the rate of survival is very stable. Beyond in the group of 23 weekers, there were also an increase of survival in the actual cohort. As a conclusion, I can say we have a very stable rate of babies with a gestational age of 23 weeks and below that is treated according to the wishes by the parents. And there are a lot of families who request transfer in our hospital because they want their babies treated with a gestational age of 23 weeks or below. We want to do this as well as possible, but we see that there is no evidence for the best way to treat these infants. We have chosen our own approach due to our observations and our experiences, but we are very convinced that it is of high importance to come in discussion with other centers, and we are convinced that together we can find the best way to treat these infants and their families. And that's why we appreciate very much the initiative of the Tiny Baby Collaborative, because we think that this is the only way to become better. And at the end, I want to show you one picture of our beautiful town situated at the beautiful River Rhine. And I thank you for your attention.
All right, thank you very much, Dr. Kribs, and we'll go ahead now and switch over to Dr. Rysavy's presentation.
Thank you, Noelle, and thank you very much, Professor Kribs. that was a really informative presentation, and I thank you for sharing that. So my goal today is to talk a little bit about what we know, what we don't know, and as Noelle mentioned, what we can learn and how we can learn it. So we surveyed our registrants, and it's really great to see so many of you show up for this webinar, that we have hundreds of people from around the world interested in how to better care for babies born this early. I think is really valuable. And I look forward in future webinars to learning from all of you, and in the discussion later today to hear a little bit about your perspectives. And I agree with Dr. Kribs that as we put our experiences together, perhaps we can better learn to care for these vulnerable patients. We surveyed everyone when they signed up for this webinar, and I was interested to see that across our respondents, 85% reported that they came from a hospital that regularly offered intensive care at 22 weeks. A few said it very much varied by which provider was on service, and some did not offer at all. But notably, most of our respondents, almost 4 out of 5, said that this changed within the past 5 years. And in fact, the majority of those said that it occurred within the last 2 years that they started to provide intensive care. And as Professor Kribs so clearly articulated, well, guidelines have changed to provide information that perhaps we should consider providing intensive care at these early gestations. We don't have very good guidance on how. And that's a very different question. And that's the purpose of this series of webinars, is to help us explore that question a little bit better. The experience of our respondents plays out in data from the United States. These data were published a couple of years ago, provided generously by the Vermont-Oxford Network. You can see here at 22 weeks, the rate of active treatment in the light blue, that's a neonatologist showing up and providing any potentially life-saving care. It was around 1 in 4 babies at 22 weeks for most of a decade. The dark blue shows the survival rate, which was 5, 6, 7% during that time. You can see that starting in 2015, there was a change. And so very consistent with what our respondents reported to us here in our survey, many hospitals have changed policies. Many neonatologists are very recently experiencing intensive care for this population, such that in 2019, of babies at Vermont-Oxford Network hospitals in the United States, the majority at 22 weeks received active treatment. And you can see the mortality or the survival rate tripled. 3 things I want to cover today. One, I want to just describe a little bit this population. I think it's useful to understand why we talk about babies born at 22 and 23 weeks. I want to talk about maybe a little bit why they're different, and then I'll talk very briefly about the work of the Tiny Baby Collaborative. At the end of this talk, we'll open for a question and answer session led by our 3 moderators. So as those who have been practicing neonatology for multiple decades, as my mentor Ed Bell has, know, babies born at extremely preterm gestations have had very different treatment over time. And the earliest gestational age for treatment has changed about 1 week every decade on average. So in the 1970s, the most premature babies treated were around 27 weeks. And in the 1980s, 26 weeks, and so on. And very recently, as we just discussed, babies at 22 weeks are being much more commonly provided intensive care at hospitals across the world. You can see how this variation plays out in some older data. We published this in the New England Journal of Medicine in 2015. And I wish to highlight here, amongst major academic centers in the United States, the rate of active treatment at each gestational age. And you can see at 26 weeks, most hospitals provided active treatment to most all babies. At 25 weeks, you can see the same. At 24 weeks, there's a slight change here, but most babies receiving active treatment. And on the other side, less than 22 weeks, 0, 0, 0, 0, 0. You do not see much active treatment. But what you see is that at 22 and 23 weeks, you have variation from 0% to 100%. So very, very big hospital to hospital differences. And I think what's happened in the past decade or so is that hospitals that have been treating have published outcomes. Other hospitals have said, okay, well, those outcomes are possible, and we see an increase in hospitals that were not providing it. And a lot of people without very much experience at these early gestational ages learning how to provide this care. How big is this group of babies? Well, here in the United States, at least, it's about 4,400 babies who were live born at 22 and 23 weeks. And I think it's notable to compare that to other populations. So fetal alcohol syndrome and Down syndrome have a very similar incidence. And I think we'd all recognize that any general pediatrician should recognize those conditions. And so I would think that, you know, in subsequent years, most any general pediatrician may encounter at times in their career babies born at 22 and 23 weeks. This is not a particularly small population. It's notable that this population, despite being 1 in 1,000 births, accounts for 1 in 7 infant deaths, that is, deaths during the first year of life. So are these babies different? Why are we focusing on this particular group? I want to first start by saying that there is a little bit of arbitrary decision making here in talking about babies at 22 and 23 weeks. Why not 22 to 24? Prematurity, after all, is a spectrum. You can see here that the average pregnancy lasts about 40 weeks from the last menstrual period, and that we have very clear nomenclature that we use to describe gradations along the spectrum of prematurity. So a late preterm infant versus a moderately preterm infant, and so on. We've used for a long time a sort of bucket category of babies born at less than or equal to 28 weeks, who we call extremely preterm. But that's a very big bucket category. It continues to grow, and I don't think we've adapted our terminology to fit the most premature babies. Within that bucket, we have no reports of survival at 20 weeks, at least that are credible that I've ever read. We do have some case reports of babies surviving at 21 weeks, but these are fairly infrequent, and at least in the literature, they're all published as case reports. That there's no cohorts of such babies. But when we look at survival at 24 weeks, most babies in most NICUs in big cohorts are surviving. And so babies at 22 and 23 weeks, maybe we pick them out because they're kind of stuck in the middle. There's a very big change here. I think it's worth noting how these babies are somewhat different, that this isn't entirely arbitrary. One of the first things that I'd point out is that the risk of stillbirth for a mom pregnant and delivering at 22 or 23 weeks is much, much higher than even later in extremely preterm gestational ages. These data are a few years old now from the Express study in Sweden, but you can see the very clear difference, multiple-fold higher at 22 weeks than at 25, say. These babies are also born for very different reasons. These data come from the Japanese Neonatal Research Network, and they reflect only live births. But you can see here the incidence of gestational hypertensive disease as a cause for delivery. And as you would expect, that incidence increases such that here when we get into moderate preterm gestational ages, you see nearly a majority of babies are born for that reason. Babies born here at 22 and 23 weeks are born under very different circumstances, frequently due to premature rupture of membranes, also frequently not shown on this slide due to conditions such as chorioamnionitis. And I think you can see that bear out on this next slide. These are data from Dustin Flannery's group, published a couple of years ago. They show the incidence of culture-proven early onset sepsis. So this was a positive culture at less than 3 days. You can see that the babies born at less than or equal to 23 weeks have a very different incidence of a positive blood culture than those born at other extremely preterm gestational ages like 26 and 27 weeks. It's a threefold difference. So these babies are not only less likely to be live born and born for different reasons, but that plays out in terms of the morbidities that we see. I also think that these sorts of findings, when we talk about management, have implications for things like antibiotic stewardship. Your pretest probability for babies born at 22 to 23 weeks is threefold higher for having a bacterial infection than it is for other extremely preterm infants. You really see the same pattern play out for all gestations across several morbidities. Here, these are data we published a couple of years ago, again using Japanese Neonatal Research Network data. When we talk about things like pneumothoraces, multiple times higher at 22 weeks and 25 or 26, any sepsis, intraventricular hemorrhage, PPHN, bowel perforation, all of these are very different incidences at 22 and 23 weeks than you see at later extremely preterm gestations. In terms of how we manage these babies, I'll also, you're seeing a clear theme here, point out that they are different. These are very nice recent data from Mikael Norman's group using Swedish National Quality Registry data. His group looked at the duration of mechanical ventilation for babies born by each gestational age week. And I've included a line here for the median, which I think helps us see the big difference. The blue line reflects 22 weeks. The median gestational age for extubation for these babies in Sweden is it's almost about 2 months. It's 56 or so days. When we look at 23 weeks, it's about a month. It's over 35 days. And when you look at 24 weeks, you see that it's about 3 weeks. 25 weeks, you see that, only about 60% of babies are ever intubated, and those that are tend to be intubated for less than a week. I think it's notable that at other extremely preterm gestations in current practice, the majority of babies actually aren't ever intubated to show up on this graph. So they're all below the median here. So these babies are born for different reasons. We talked about how they have very different risks of morbidity. We treat them different when it comes to mechanical ventilation. We expose them to very different medications. These are data that come from the pediatrics group. This is about 1 in 5 of all NICUs in the United States. Very simple study that just shows the top medications used by each gestational age. 22, 23, 24 weeks. And as you can imagine, the top ones are things like ampicillin, gentamicin, and surfactant. But look at this. The number 4 most used medication at 22 and 23 weeks is dopamine. You don't see that pattern play out at later gestational ages. I think it's actually quite surprising and perhaps a bit concerning that these babies on average were exposed to more dopamine, or more of them were exposed to dopamine than they were caffeine. I don't think any rational neonatologist would say that that's the way that they should be treated. And I think that that probably highlights that we have difficulties, whether it be with fluid management due to the high insensible losses, maybe knowledge of what appropriate blood pressures are. These are some of the questions that came in from attendees. Maybe difficulties with ventilation and appropriate respiratory support, that the mean airway pressures, it's easy to get too high. But I think this sort of pattern suggests that we are treating these babies a little differently. Maybe they are a little bit different. We know from physiology and anatomy that during this period, 21, 22, 23, 24 weeks, there are major changes in development. Here you can see several of those. I think the thing people frequently are most attuned to is that the skin is so different at 21, 22 weeks versus later extremely preterm gestational ages. These are histology slides published by Reed et al., and you can see the difference in keratin. And this really affects management when it comes to things like transepidermal water loss. But we also have smaller airways, blood vessel diameters, differences in the alveoli, both in the number and perhaps in their composition. For example, the development of elastin seems to take place in this period of gestation. So the ability to exhale may be slightly different. We have differences in pulmonary vascular branching. You might have seen that play out perhaps in the PPHN data. We have fewer nephrons, an immature adrenal cortex. The cardiac myofibrils are a little bit different. Vascular walls are a little bit thinner, and the PDA may handle slightly differently. That'll be an upcoming conversation with during a webinar. We have developing adrenergic receptors. The nervous system is certainly developing, and all of these things may play into different management needs. And finally, in addition to the fact that babies are born differently, they have different morbidities, that we treat them differently, I'd like to highlight that they have different outcomes. These are data from the Neonatal Research Network here in the United States, published by Ed Bell and others last year. And you can see here the rate of death at each gestational age week. And as you would expect, it decreases between 22 and 26 weeks in a very pronounced way. I'd also like to highlight, though, that when we look at long-term outcomes, the rate of survival without NDI substantially increases in a very similar fashion. So from all of this, I hope you take away these babies arguably are different, and whether we draw the line at 24 weeks or 23 and a half, or exactly where that line in the sand is, I think is probably a little bit arbitrary on that spectrum of prematurity. But for our purposes, I think it's useful to talk about the babies at 22 and 23 weeks as being somewhat distinct from those of more mature gestational ages. So they're different. Well, what do we know about treating them differently? These are very nice data from Leanne Pavlik, and her group published a couple of years ago. She looked at all clinical trials in PubMed that were published during a period of an entire decade that included extremely preterm infants. Kudos to the neonatal community for having over 200 clinical trials to study the care of extremely preterm infants. There were over 32,000 randomized infants. But it's notable that of those babies, only about 450, that's less than 1.5%, were determined to be less than 24 weeks of gestation. So when we talk about how to manage babies born at 22 and 23 weeks, Professor Kribs raised the point, well, should we extrapolate from more mature babies? I think the data that we have from trials, that's all we can do. The effect for any babies less than 24 weeks is almost entirely washed out. That 1.4% is a drop in the ocean. But I think it does, I've just shown you how different these babies are. I think it should make us wonder, are they somewhat different? Should we treat them differently? And that's something I hope we can continue to discuss and that the Tiny Baby Collaborative can continue to elaborate on. So just a couple of notes here on the history of the collaborative. As you all know, I've shown that care varies across the United States. It also varies around the world. I show here several publications, this is not all inclusive, of outcomes in different countries during recent years, from 0% survival in Victoria, Australia, to 58% survival across the country of Sweden, when we're talking about admitted babies. Several years ago, our group got together with single centers that had published really high rates of survival to say, what do you do? We don't have trial data. We don't know how to best care for these babies. What have you learned? Your outcomes are good. Are you doing some of the same things that we are? Are you doing things differently? How can we improve? And so I've highlighted a few of those groups here. We first met in May of 2019 at the PAS meeting. Here you can see the attendees, several of whom are on this webinar. Thank you for coming. And in the subsequent years, we've studied together, we've conducted informal surveys of practices, benefited from exchanges about troubleshooting and the care of individual patients, or groups of patients. We've conducted site visits in Japan and in Sweden and Germany and to the US. We've had multiple publications now, and I think importantly learned a lot from the sharing of aggregate data. So just, using the same standardized criteria, show us your rates of morbidity, show us your rates of outcomes. It's hard to compare what's in the literature because we don't all count things the same way. But doing this in an intentional way was really revealing. So showing a few of those data here, you can see our rates of survival. And I've grouped the Japanese centers together. Each one is relatively small compared to some of the others. But you can see here rates of NICU admission at each center during a 5-year period or a 6-year period. And you can see rates of survival. All fairly similar. But it's been very educational to look at things like differences in morbidities. I will humbly admit that when I started this project and in my own experience, I had just assumed that every baby at 22 weeks needed to be on oxygen at 36 weeks, that our definition for bronchopulmonary dysplasia wasn't really built for 22-week babies. I've said that a few times to colleagues, to trainees, to parents. But learning from the other centers in the collaborative, I see that that's not true everywhere. And in Cologne, for example, we see that fewer than half of babies are on oxygen at 22 weeks. Fewer of half of 22-week babies are on oxygen at 36 weeks, excuse me. Similarly, we see differences in the rate of retinopathy of prematurity. And so you can see here at Iowa, the rates are much lower than some of our colleagues. And I think that there's something here. We do have very big differences in some of our management, and perhaps we can learn from each other about where these differences in outcomes come from. We have recently started sharing individual level data. So the multi-site inventory of neonatal perinatal interventions, or the mini study, kicked off this year. And we now have a couple of dozen centers from across the world participating. Very importantly, this study collects data on all births at 22 to 23 weeks, not just live births and not just NICU-admitted infants. And I think a few unique features of this study, which I hope will bear fruit, are that we have a data set that was developed by experienced centers who've been taking care of babies born this early for decades. So some of the questions are perhaps a little different than in many other neonatal databases. The international aspect is really useful. We found that a lot of differences exist across countries. So many US hospitals practice similarly, and some of the Swedish hospitals practice similarly, some of the Japanese hospitals practice similarly. But when we compare across these big differences, across these big distances, we can learn from each other. And also the highlighting of the role of the obstetrician in outcomes by collecting all births, I think is really important. As I've shown you, stillbirth is a common outcome at these early gestational ages. This study is just starting. And we would certainly welcome participation of others. I've included here the email address of our lead coordinator, Elliot. And you're also welcome to email me if you have interest in this. So to wrap up our talks here, I want to say that children are not just small adults, and I hope that you've seen that babies born at 22 and 23 weeks are a little bit different. They're not just small, extremely preterm infants. I think that our data so far suggests that prematurity is not the explanation for all outcomes, that these rates of morbidities and rates of survival are not just written in the stars, but treatment, what we do, impacts how our babies do. And finally, I hope I've highlighted that when we choose to provide intensive care, we really need to better understand what we're doing, and research in this area is direly needed. So with that, I'd like to thank you and open up for a question and answer with our moderators.
Thank you very much, Matt and Angela. They were really informative talks, and I couldn't agree more with your final slides. I'm going to kick off really and brings a somewhat UK perspective. I wanted to thank you, first of all, to all those who've submitted questions. I'm going to actually keep those related to future webinars. We're not going to mention those. That's antenatal counselling, ventilation, skin management, hemodynamics, because they're in future webinars. But I really want to pick upon that international perspective and also the data. So I really commend the Tiny Baby Collaborative. I think it's absolutely important that we get together internationally and share our data. But I guess I pose a challenge question to you, Matt, in terms of how are we going to ensure that we harmonise these data with the correct denominators? And you mentioned in your talks that it's difficult to even define what signs of life are, or to be absolutely certain we have our denominators correct with what's a live birth. How are we going to ensure that these comparisons are actually going to be valid? And I wanted to touch upon another question, Angela, later on, because I'm amazed at your high survival rates, and I'll share some UK data if we have time. But yeah, first of all, Matt, about data and denominators.
Thank you. You raise a really important question, and honestly, our policy is call it what you called it clinically. We don't have a, if you never listen for a heart rate, is there a heart rate? This is a sort of rhetorical question. I think that we clinically make decisions and say this baby's stillborn or this baby's liveborn. Certainly, there are different reasons in different countries. It's a well-established literature that babies are categorized one way or the other. And I think that for our purposes to count, it's very important to call all births as our denominator. And so thank you for raising that very important point.
Yeah, no, I absolutely think that's hugely important. We've looked at our UK data recently, and we have about 300 births at 22 weeks per year, but only 150 live births reported. And in 4 years, we've only had 242 babies receive survival-focused care. Our survival to discharge is actually a lot lower. Of those receiving survival-focused care, it's about 20%, and of those admitted to neonatal units, about 30%. So I think if those numbers are all valid, then there is so much scope we need to learn from each other internationally to see how we can improve the care. On that note, though, I wanted to just address one of the questions that have come in. So a few questions have come in related about change practice, and that's also been relevant in the UK, partly because our survival rates haven't been so high. So there is this sort of low morale among staff. We spend so much effort and love looking after these babies, yet the survival is still quite low. How do you reduce sort of your staff bias about the care of these babies? That was one of the questions that came in.
Professor Kribs, would you like to answer that?
Yes, I think that's very important to have a close collaboration between all professions who are involved in the whole process. We have to collaborate between midwives, obstetricians, anesthesiologists, pediatricians, and neonatologists. And we have first to define what do we want. In which condition do we want to offer active treatment to the parents? Who has to give the information to the parents? And we have to make sure that everybody is informed about our possibilities, about our way to manage the babies, and everybody who is involved in the care of the mother has also to know that it is important that the mother is informed by neonatologists as well as obstetricians and midwives. And then we have to speak with the parents after having discussed the case together. We have to speak together with the parents. We have to make a shared decision with the mother, and everybody of the team must know that he is involved in the process. Only then it will be possible to make a to change something in hospital. And that's why I presented the index case. The index case was the point where we started to go in this interaction between the different professions, and to make sure that the case is discussed in the team with all professions before we speak with the parents. And after having speak with the parents, we make shared decision with the parents. And if you go this this way, I think it's possible to have the whole team in the boat. And if you want to improve something for the babies, it's necessary to have everybody in the boat.
Thank you, Angela. I think also the question was relating to the staff that I would be interested to hear how you clearly your survival rates improved over time. And was there some sort of change management with the team in terms of sharing the survival data, encouraging them, raising morale because you're feeding back that survival's improving? Did that happen in Germany in your unit?
Yes. And I think that is one important point.
Thank you. Danielle, sorry, I'm just looking at time. Danielle, your question's up, and I'll probably hand over to you, actually.
Okay, great. I was just going to chime in if I could pose a challenge to the teams as well. I think it's fantastic that we have over 340, I think, listening in live, as well as many who will be watching this on the website later on because of various time zones. I completely agree with what Professor Kribs has shared of really having the full multidisciplinary team involved, and just to highlight how really important it is to think of our family members as part of that team. Really crucial at the designing phase as we're changing processes, we're thinking about the big picture. And I know in my unit, that has been really critical of having a family advisory council and having them on our QI teams. And then as a full group, multidisciplinary, from OB to NICU to pediatrics, looking at the data both within the NICU, but really the emphasis on follow through and thinking about how these babies, function in the community later on. I think our inpatient team doesn't always see that side of things. And so the more that we can, connect the dots and provide the big picture, I think that's, really crucial for that change management. I don't know, Matt, if you had any comments before I bring up another question from the group. It's going to be so hard to get in all the wonderful questions. We'll just have time for a few.
Yeah, thank you. My only comment is just to say, when we've discussed this as a group, and one of our first questions when we started doing surveys to these sites that had high rates of survival is, what did you do? Why do you have good outcomes? And almost uniformly, everybody said, well, we know babies born this early can do well. And I think that fact that it's not a belief, it's not an abstraction, it's not, hey, I read this in the literature, but it's, hey, I actually saw it with my own eyes. And you kind of heard that from Professor Kribs in her index case, is really convincing to people, and I think really, really important. Thank you.
And if we have one time for an additional question, there were quite a few questions focused on kind of centers of excellence. Should we think about having these 22, 23 week infants cared for similar to our cardiac patients, at true centers of excellence, or do we think about having specialized teams at all hospitals that are caring for the very preterm population? As you said, Matt, that group is quite diverse, thinking of all babies less than 28 weeks. So I think we had quite a bit of interest in that concept. And then to add my spin to that, what does that mean in urban as well as rural areas? Thinking, I practice in a place where I'm the only NICU in an entire state, and that is a very different setting than an urban, type of situation. So thinking about centers of excellence, how does that, impact care in different geographies, as we think about also variation in care and how that affects health equity?
Thank you. I think you raise a really valuable point, and I think your point on equity is right on too. One of the things that's fascinated me in this area is that you could show up to a hospital that doesn't resuscitate at 22 weeks with the intent of desiring resuscitation and be told, I'm sorry, that's not possible. And depending on your area, you can go to a nearby hospital and know that. And there's no public information that we make as medical providers available to families. And I honestly, I just don't think that that's right. So that's something that I think could be better. And whether that's from making open claims publicly, and I'm speaking from a US perspective, that, here's what we provide, whether that's having some sort of, you use the term center of excellence, whatever that looks like. I think those are different ways that one could do that, but just having some public information available so that families don't find themselves in that circumstance. Unfortunately, that is something that happens, and that is something that we will hear at places that provide care at intensive care at 22 weeks. Well, I went somewhere and they said no, and then I saw you online or something, and that's not a good place for a family to be in. So more transparency there from the U.S. perspective would be valuable.
Professor Kribs, any comment from the German perspective on
yes,
kind of the regionalization of this care? And then I think this is our last question.
Yes, and I think in Germany we have the problem that the situation is very different in the different sub-states of Germany, and in our state, in Northern Westphalia, there are a lot of level 3 centers, but not all of these level 3 centers offers care to the 22-weekers. And it's not, the information is not public available, but the centers are working close together. For example, today we had the transfer of a mother with imminent birth with 23 weeks and a very growth retarded infant, and the other level 3 centers said, that's nothing for us, you have to go to Cologne, but that's only a distance of 30 kilometers. So we are very close together, and we can work closely together. And I think this situation is very different, for example, in Bavarian or in the northern of Germany, where the centers are far away each from the other. And I think a kind of centralization is necessary to improve outcome. In our center, the improvement went also along with an increase of the number of these infants. If you have the experience that everybody knows what is to do if such an infant is born, is very important for improvement of the outcomes for infants. And so I think we have to do first we have to do a centralization for these infants. And if we have more knowledge and have more standards and results from studies, then perhaps we go in a situation where in more centers these babies are treated. But first, we have to centralize to have experience in this single center.
All right. Well, thank you so much for our speakers and our guest moderators. I just wanted to remind everyone that this is going to be available on the Tiny Baby Collaborative website. We'll try to get that posted here soon, and that we will reach out to everyone who registered about the next webinar. And the next one will be on June 22nd, and that will be the one here, as noted, that'll focus on fluid management and skin care. So thank you very much for everyone who attended today.
Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you.